So guidelines are important. In infectious diseases, I feel like we're always waiting for guidelines to be revised for lots of different reasons. But one is organisms change, right? Our diagnostics change, everything can change. So I feel like, if you follow the literature, you know what the guidelines should say, and then you're waiting and waiting and waiting for that to occur so that people can implement those in practice. So I have kind of a couple of passionate feelings about that, I would say. One is, why wait? When you know the literature and see where things are going, that's the time to implement change and not wait and see what a society does. But the other one is that we really take guidelines too far. Guidelines are meant to not be rules. They're meant to be guidance, just exactly as right there in the name, guideline, guide, not hard and fast rules. And unfortunately, they almost become weaponized after they come out in the United States, where sometimes payers then use them and say, if it's not in the guideline, we're not going to use it or pay for it. Or regulators can use it as well to say, these are the agents that you should be using and that we recognize as what should be used for that condition. And I think that's really problematic. They really are not designed to be that way. Guidelines also generally report the level of evidence that recommendations come from. And some of those are high levels of evidence and some of them are low levels of evidence. And if both the high and low level of evidence come out and be into a guideline that is seen as a hard and fast rule, that's really a mistake. So I think that as useful as they are, and I do think that they are useful, we tend to take it too far. And they're a recommendation. The recommendations are obviously, hopefully, evidence-based and should be a best practice, but shouldn't be the only practice. There's exceptions to every rule.